Hi everyone and welcome to 8.8. My name is Nina Ali and today we're going to be talking about defending the impossible. A little bit about myself. My name is Nina Ali. I am the executive director of the Biohacking Village at DEF CON. I have worked in biomedical technology and security in New York City for the past 15 years. I've done a couple of other things in my life. I've worked for the Department of Defense. I was in the Marine Corps. So with all of that said, I just want to ask a couple of questions in the audience to make sure that we are all thinking about different things while we have this talk. So are you a programmer? Are you an engineer? Are you a clinician? Are you a physician? Perhaps you're a policymaker, or are you a patient? I have this tendency to think that we are all patients because we all at some point go to the doctor. So therefore, we are all inherently invested and involved in making sure that healthcare works. A couple of definitions. We are all familiar with security researchers, also known as hackers, and we take our computer expertise to work on technological problems. And there are also biohackers. There are also English. And there are also biohackers, also known as citizen scientists. We are the folks that do the DIY bio, and we find different solutions for problems that we find, and we may not have the resources such as money or time to work on these, but we focus and we learn about what we're doing and try to create change. Just like the human body, there are very different systems in computers. So when you think about how the computer is set up and the different applications that you're going through in the different parts of the hardware, it's very parallel to how the body works. Every system has its own different kind of muscles, different kind of molecular setup. So everything interacts and each part makes the next part better. So we are in the middle of COVID, and I just want to highlight some of the things that the hacker community and the biohacking community have helped with to benefit society and move it forward through these hard times. So there's been a larger substantial push for med tech, for all of these folks to be more involved. Do it again. So I just wanted to point out some of the help that the hacker community and the citizen scientists have helped with industry so that we can all get through this together. And a couple of things to remember as we keep going on. There has been exponential growth in the healthcare system, especially now because we are doing more of the digital medicine, and there's a human at the beginning and end of all of these workflows. Technology is not industry specific. We can all go on overstack.com and pull a line of code out and put that into any of the devices, the software, the programming that we're working on, and move forward from there. And also, I tend to think that people think healthcare is just about the patient and the physician, but there's so much more to that. In the facility itself, you also have to concern yourself with water, electricity, the internet, infrastructure, finance, and transportation, because that does also play into it. So my other title for this talk is Never Gonna Give You Up the Data and Never Gonna Let You Down the Patient. So you have been officially rickrolled. So how did the healthcare industry react to COVID? A little background on how and why healthcare is so interesting for a lot of people. It's very attractive because there's more victims in one place. Unfortunately, there's a lot of data in one So why are hospitals so interesting and attractive for criminals? There's a lot of information in one place. I'm going to change that. So why are hospitals so interesting and attractive for criminals? There's more information in one place. Think about all that data that's flowing through all those different mechanisms, different applications, and they all end up in one EMR, for example, or one pacemaker. So who wants this medical data? Everyone wants this data. The physicians want the data, the patients want the data, banks, life insurance. There's a lot of people that are consumed with knowing what is going on with the patient. And what can they do with this data? There are a lot of options. As we all know, unfortunately, you can hurt a patient through some of these things, but simultaneously and more so, you can help patients move forward with their life in a better way. So what does the system look like to a hacker? There's so much there for people to take advantage of. Think about your bank or your credit card, for example. If you lost your credit card, the most information that they will have on you is your name and the number on the credit card, and maybe a couple of other things about you. However, if you lose your EMR information, your medical information, they have all of this. Your first, middle name, your address, your date of birth, your social security number, or your national number. A lot of information is taken in when you are a patient. So a lot of what we have to do as biohacker folks, as security researchers, is to make sure that all of this data maintains its integrity and stays within the confines of the medical care system. Also, what we have learned through COVID and how its effects on people have been is that there's a lot of inequity. So as we continue to move forward with what we are working on, we are looking for more equity in healthcare, in financial issues, in food deserts, in prevention of food deserts, and better education. Because again, there is a patient at the beginning and end of this workflow, and making sure that they understand their care and they understand it at a level that they can speak about it makes them better patients and helps them understand how their future is affected by it. Gender issues, making sure that women and people of color are heard and their situations are taken seriously. Disability, that seems to be very overlooked, and just ensuring that those folks are heard and seen and their care is taken into consideration as well. And also cultural issues. Statistically, there in the United States, there are 5% of physicians are African American Black, and 5.8% of physicians are Latino. So there's a large chasm, there's a large disparity of how you can communicate with your physician, because they may or may not understand you from a cultural standpoint, and that does have an effect on care and how you are being taken care of, as well as infrastructure. Because we are moving more toward medical being digitalized, ensuring that you have adequate internet so that you can connect to your physician is a very big deal, and that's happened in quite a lot of countries. So how are we moving on with COVID being currently taking place? We are moving again more toward digital medicine and telehealth. So it was a blossoming field right before COVID, and as soon as COVID hit and we couldn't necessarily go to our physicians, it became a major big deal so that people could still continue their care and that they could be taken care of. So this leads to a continuous monitoring of patient status, which I think is much better, because under normal circumstances, we go for an annual visit, annual being one data point. So this way, once you have continuous monitoring of patient care, you can have different data points that you can instruct the patient better, because you have more knowledge about how they actually are. Ease of use for patients, something I continue to talk through with people, is we are building technology for 4 different generations. We are building for the baby boomer generation who did not grow up with computers. We are building for Gen X who were brought up with computers, however there was no security we are also building for Gen Z who got computers with security, and we are also building for the millennials. So we have to build those things, the applications, with all of these generations in mind, because we are still all in the workforce and we are still all very much patients. Digital medicine has also democratized care. People can see their physicians now without having to take days off, without having to go for the very long transportation visits to go see them. And so again, when you are building your applications, when you are building resources for folks, these are things to think about. Also, there's a link, please read that. I think it's very good. With clinical trials, traditionally, they have not been very diverse. In America, I believe it's 70% of clinical trials have been based on cis white men, and that medication is also then given to women and people of colors and trans folks and things like that. And that creates, that's another chasm. But with digital medicine being more involved now, we have the opportunity to enhance these trials by caring for people at home and asking them various different questions, because technology has given us less barriers and ways to reach people in their homes, on their daily lives, and getting that data into the trial and better realization in longitudinal data and real-time insight with larger cohorts of study. Threat modeling has become a major issue. Recently, the TrickBot came out in the UHS system in America, and while it is a black swan event, we have to take into consideration how are we mapping or not mapping the systems that we currently have. So do we have anything mapped out? And if not, how can we get started? Because we need to know where our assets are, and because it's a 365-day And because it's a 366 with a leap year, 24-hour, 7-day-a-week model that we're working with, this industry is constantly moving, and so are the items inside this hospital. So we have to know where things are so that we can mitigate risk and properly protect what we're working on. So a couple of links that are set here. Stride, which is by Adam Shostak. The FDA has started to mandate that medical device manufacturers start building out their threat models, and when they provide these devices to the hospitals, I gotta start that again. The FDA has started to mandate that medical device manufacturers start providing threat models of their devices and giving them over to the hospitals. This way they can start implementing that change in the hospital itself, which is great. The other part of this is Includes No Dirt has taken into context medical devices and the medical infrastructure and the medical industry itself, and has started to provide more insight and a more inclined, inclusive, specific way of threat modeling. So that's something else to start thinking about as you create applications, as you create devices, and as we start to reimagine and reinvent how healthcare will be moving forward. So I talked a little bit about this before, Microsoft XP and Microsoft Windows 95. A lot of devices that are currently being built are built on Linux platforms, and we are still using Microsoft XP and Windows 95 as the operating system platforms. One of the major issues with these platforms as the operating systems is that they've kind of been put to bed already. They're end of life, they are no longer supported. However, it's hard for the industry to move forward from it because so many of the applications that they're built, that the devices are built for, work specifically with these. So there is a movement to perhaps move a lot of the medical devices and the electronic medical records to the cloud. That is still being worked on because there's a lot of detail that goes into this situation. Recent issues that came up with Microsoft is that Microsoft XP, the source code was released, and that creates a lot of problems just in general for a lot of industries that still work from XP. And also TrickBot was recently found in the UHS system over here, as I said before. And about that, Microsoft took back command and control of their code so that they could disable the IPs and work on this to better be a resource for the industries that might be under attack from this. This is still a story that's in progress, so we will have to catch up with it and see what happens. A little bit about readiness and resilience. I tend to think that there are not too many information security teams in hospitals. So a couple of suggestions around all of this is perhaps we create virtual and volunteer CISOs to help with healthcare. And a lot of around how I think about this is that they don't necessarily have to be from the healthcare industry. It may actually be better that they come from other industries so that they can lend their insight and foresight into how healthcare is running or should run, and maybe that'll create a better situation. COVID has showed us that we do need more education around science. I think my favorite science quote when you ask someone about biology is that mitochondria is the powerhouse of the cell, which is absolutely correct, but there's so much more and so much more beauty to biology. And I understand that sometimes it's a hard concept to take in, but it's also part of your healthcare, which means maybe we need to ingrain that a little more, especially due to the current circumstances. And also with COVID, there's a lack of trust in scientific knowledge right now. So I think better education in how COVID works on your lungs and in your body would promote better resilience for how people are reacting to it. Using different softwares to test emulated ransom attacks in a production environment, which is mirrored, not that we're going into production to do this, but it would show folks where things are, how they're attacked, better ways to create barriers around it. There is defense in depth, yes, but we also need to know where to put those defense measures. Full cyber range for testing, which plays into that. Zero trust is starting to become a very big deal, and microsegmentation. So if you're not familiar with zero trust, the security industry is very familiar with trust but verify, where zero trust is never trust, always verify. So you will always, as you walk through your systems at work, you will continuously have to prove who you are, and it's an escalation of privilege and whether you have that ability to get into things or not. And also, shameless plug for the biohacking village, we have a pseudo hospital set up where manufacturers come in and they have face-to-face talks with the different hacker folks, and there are communications around any vulnerabilities, any issues, and it's an open dialogue. And that's what we're trying to create, because for so long the healthcare industry has been afraid to have conversation with us as hackers, and opening those barriers and those doors gives us as hackers credentials into what we're doing to make things better, as well as providing the medical device manufacturers credence to know that their work is valid and they've done a great job. And if there's something that needs to be fixed, they have us on the other end that they can call, and we can communicate and work through those things together. And a couple of takeaways, just some things that I may or may not have mentioned, but if you heard nothing else that I had a conversation about, this would be the one slide that you can take a picture of and move forward with in your places of work. Software as a medical device, this is where digital medicine comes in. The FDA has a lot of different guidances on this. I would suggest going to their website to learn more. Again, I talked about zero trust, never trust, always verify. Bug bounty and coordinated disclosure. Again, we do this at the biohacking village, but ensure that the company that you work on has a bug bounty and a coordinated disclosure program, so that we as hackers or just whoever can put something into your company to say, this is what we found, we would love to help you with it, please talk to us. About the medical industry, remembering that it's a 24-hour, 7-day-a-week, 365-day industry. We can have tabletops and have discussions around things that may or may not go on, but we also have to feel the impact of these things. So creating a cyber range where these things have a real-time impact on the humans that are involved, and gives you that reaction time and gives you the feel, is really handy. Workflows and threat models, understanding that there's a patient at the beginning and end of this, and also a physician at the beginning and end of this. Very important for how things work, again, generationally as well. And also understanding that the applications that we are building, how they work into the current medical system. Hire researchers, hire people that want to help you make your devices better. Post-incident legislature, there are currently none. So what I mean by this are, if a patient, so some things that we work on at different conferences, whether it be at the Biohacking Village or at CyberMed Summit, which is run by Christian de Meffenj of Tele, a lot of physicians are not made aware of the technology behind what's in the medical devices, such as an insulin pump or a pacemaker. And with that said, when they're working on a patient, they may think that something happened with the patient rather than something happened with the technology that they're using. And instead of taking the device that may have interrupted care for the patient, they may just re-image it rather than going back and scoping out the issue and saying what happened with this in particular. And it may not have been anything, but just to ensure that they've covered everything. We, current state, do not have legislature or any mandates that dictate folks to do that, but at future state, it may be something to do. Other than that, global initiatives that may be important, patient pertinence, again, protection of patient data, so important. It scopes out into so many different industries and how it can hurt a patient. Worldwide, there are different initiatives that countries are taking. So China has One Belt, One Road, China 2020, where they are pulling out data to ensure patient safety, privacy, data culling, and also how to better the health of that community, as well as Saudi Arabia. And the UN, the United Nations, has sustainable goals where they're trying to either bring up the percentage of people going to their healthcare provider and getting care, or perhaps lowering HIV status in the world. Literacy, as I had conversation about before, just making sure that you as a patient, as a physician, as an engineer, as a policy person, understand the breadth and depth of the medical ecosystem. Just making sure, with literacy, just making sure that you as a patient, as a physician, as an engineer, as a policymaker, understand the ecosystem in the biomedical area so that you can help make better laws, better regulations for patients and for yourselves working in this industry. And lastly, the Hippocratic Oath. A lot of people understand that it's the do no harm, which is brilliant, and that's for the physician. That is the physician oath that they take when they become doctors. There's a paper by I Am the Cavalry that also says do no harm and it's an oath taken by the medical device manufacturers. Also brilliant. At the end of that paper, I also stipulate that the healthcare delivery organizations, that the hospitals, should also take this oath. A lot of the reason is because I, as a patient, I may not physically be there. However, my data, my binary, my information, and my perhaps genomes as well are in that hospital system, and I think they should also take that Hippocratic oath of do no harm with my data, with my genome, with my binary information. So thank you so much for coming to this talk. I am available if you want to have a conversation with me, Nina at villagebeat.io, and I am also on Twitter, DC_BHV, and this year's DEF CON and this year's DEF CON talks are also on YouTube if you would like to see those as well. Thank you for coming. I appreciate you very much. Please reach out if you have any questions. I appreciate you all. Thank you.